speech about Dr. Maha Omar, interesting cases.
Good afternoon, all. I am Maha Omar, lecturer of radiology at Ain Shams University. I'm going to present some body interesting cases. This session is going to be interactive session, so I would like you all to scan the QR code in front of you, and it will be also shown here. When you scan the QR code, you will find 5 questions. I will go through them through my presentation, and I will tell you each question to be answered during the presentation, okay? Okay, now let's start. This is the QR code again. And case 1. The clinical data. Our patient are 45-year-old female patient who presented with recurrent attacks of dyspepsia, epigastric pain, and diarrhea that are not responding to ordinary treatment. The patient performed multiphasic CT of the abdomen with oral and IV contrast. And these are the images. The first scan is the early arterial phase scan. The second phase, the late arterial phase. The portovenous phase. Okay. The venous phase. It's the same. Okay. Okay, for the sake of time, the delayed phase is withheld. It's not important for the diagnosis, okay? So I would like you all to answer this question now. This question number 1. Where do you think the abnormality is? Is it in the stomach, in the duodenum, the pancreas, or the bowel? You can scan the QR code and choose question number 1 and submit your answer. I'm going to give you about 10 seconds to do so. Okay. Can you please put the answers on the screen? Okay, that's nice. We had 36.8% for the pancreas, 36.8% for the stomach, 21% for the bowel, and 5.3% for the duodenum. Okay. We'll go for the next question. I will put the right answers at the end of the studies, okay? The next question is question number 2. What is the visualized abnormality? Is it A, an inflammatory process, B, an enhancing mass, C, enlarged lymph nodes, or D, an anatomical variant? You will go through the QR code and choose question number 2 and submit your answers. I will give you about 10 seconds to do so. Okay, would you put the answers on the screen, please? Okay, we had inflammatory process, 55.6%. Inflammatory process, 55.6%. Anatomical variant, 22.2%. Okay, enhancing mass, 22.2%, and no one chose enlarged lymph nodes. Okay. I will also postpone the answers till the next study. So the patient underwent MRI dynamic study of the abdomen with IV contrast to confirm the diagnosis that was shown on CT images. This is the axial diffusion images. Okay. The spare images, the T2 fat set. Okay. The axial T2 images. Yes, please, thank you. Yes, that's. Okay, I will repeat the axial T2 images. Okay. The post-contrast dynamic study will start by the pre-contrast T1 fat sat, followed by other phases of the study. This is the pre-contrast phase. The early arterial phase. The late arterial phase. And the portovenous phase. I think. Okay, I think this is enough. Okay. So now, after the MRI study, where is the abnormality? Is it the same choices? We have A, stomach, B, duodenum, C, pancreas, or D, the bowel. You have 10 seconds. Okay, would you put the answers on the screen, please? Yes, we have 8 votes, 61.5% for the pancreas, which is actually the correct answer. We have 23% for the stomach, 1 for 7.7% for the bowel, and 7.7% for the duodenum. Okay, so the correct answer is the pancreas. Let's have a closer look. Now there is an enhancing soft tissue mass lesion that is seen at the junction. What? Vein? Okay. Now we have enhancing soft tissue mass lesion that is seen at the junction between the body and tail of pancreas. Can I have the marker for 1 second, please? Here, this yellow circle. This enhancement continues through the different phases, starting from the early arterial phase to the portovenous phase. It's also very obvious here in the coronal images. About the MRI, this mass had true diffusion restriction. The ADC picture is not here, but it was dark in the ADC. In the spare images and T2, it was high signal. And the post-contrast, the the pre-contrast T1, it was low signal, and then it had early arterial enhancement that continues through phases of the study, the same as the CT study. So sometimes it only takes one image to tell the story. The final diagnosis of our patient is pancreatic neuroendocrine tumor, specifically gastrinoma. Our take-home message: in case of resistant peptic ulcer disease, please search for gastrinomas. Arterial phase post-contrast imaging, especially the early arterial phase, is essential for diagnosis. 60% of gastrinomas are malignant, so once diagnosed, search for metastasis. PET-CT using gallium dotatate has an important role in detection and staging of such tumors, as Dr. Rasha told us in the earlier session. Okay, case number 2, the clinical data. We have 55-year-old female patient presented with epigastric pain, vomiting, and jaundice. Her ultrasound showed bilateral adnexal masses. The patient underwent dynamic MRI of the abdomen and pelvis with IV contrast. These are the axial T2 images of the pelvis. Okay. The axial T1 fat sat pre-contrast. Of the pelvis. Okay. The post-contrast T1 fat sat for the pelvis also. And then the abdominal study, the coronal T2 weighted image. Actually, this is the key of diagnosis of the patient, so I am going to put it in a very slow motion. Okay. The axial T2 weighted images of the abdomen. The T1 post-contrast facet in the portovenous phase of the abdomen also. So, apart from the enhancing bilateral ovarian masses, what else can you see? You can actually choose more than one answer. Can you see A, colonic mass, B, intrahepatic biliary dilatation, C, gastric lesion, D, enlarged abdominal lymph nodes? You scan the QR code and choose question number 4 and submit your answer. Can you put the answers on the screen? Okay, so we have intrahepatic biliary dilatation, 8 responses, 72.7%, gastric lesion, 54.5%, enlarged abdominal lymph nodes, 36.4%, and colonic mass, 9.1%. Okay, we will postpone the answer also for the next study. So the patient underwent MRCP for the biliary dilatation. The coronal T2 weighted images again in the MRCP study. This is the 3D MRCP study. Okay. the MIP MRCP images. And now for our last question. What do you think causing the biliary obstruction in this patient? Is it A, malignant biliary neoplasm, perihilar cholangiocarcinoma or Klatskin tumor? Is it B, benign CVD structure? C, biliary confluence compression by lymph node? Or D, metastasis of nearby neoplasm? You scan the QR code, choose question number 5, and submit your answer. The last question. Can you put the answers? Okay, we have 9 votes, 64.3% for malignant biliary neoplasm, perihilar cholangiocarcinoma, and 21% biliary confluence compression by lymph nodes, and only 1 response, 7% for benign CVD structure, and 1 response for metastasis of nearby neoplasm. Okay, so let's have a closer look. Actually, the correct answer is metastasis of nearby neoplasm, and I will explain the case now. Okay, as we can see here, there is an invasive gastric lesion that's seen invading the whole layers of the gastric wall, reaching the serosal layer. Okay, this lesion is inseparable from the pancreatic body, and it also has an associated thickening of the peritoneal covering together with peritoneal soft tissue sheets. As we can see here, the peritoneal thickening here and the soft tissue enhancing sheets presenting in the peritoneum. About the biliary dilatation actually stopped at the level of the hepatic hilum. There is no sizable soft tissue lesions, but there is soft tissue sheets of intermediate T2 signal intensity that had post-contrast enhancement in the post-contrast images. The final diagnosis of our patient is metastatic gastric cancer with peritoneal carcinomatosis and bilateral ovarian Krukenberg tumors. Okay, so what about the biliary dilatation? Actually, biliary biopsy of the same patient revealed no evidence of malignant cells, and the patient responded very well to targeted gastric chemotherapy, and jaundice subsided. We have a companion case in the literature that was published in 2021 with a research article named "It's Not Always a Cholangiocarcinoma, Unusual Peritoneal Carcinomatosis Revealing Gastric Adenocarcinoma." And we have almost a case identical to our case with intrahepatic biliary dilatation and hilar obstruction that was found to be caused by the peritoneal carcinomatosis from the metastatic gastric cancer, not from perihilar cholangiocarcinoma. So our take-home message: in case of bilateral enhancing ovarian masses, suspect Krukenberg tumors and search for the primary site. The commonest primary sites are the stomach and the colon, so check them carefully. Secondary peritoneal carcinomatosis from gastric cancer can cause biliary obstruction in rare cases. Not all perihilar biliary obstruction is caused by Klatskin tumors. Thank you.
بشكر دكتورة مها على الحالات very interesting cases. Any questions بالنسبة للسبيكرز كلهم؟
Any questions? Okay, thank you so much.
طيب أنا بالنسبة لي بس هسأل سؤال دكتورة رشا أولاً. دكتورة رشا اديت لنا برزنتيشن رائعة على الرول اوف MRI في البانكرياس. طب إيه دور الCT النهاردة؟ هل I'll go directly for an MRI؟
هو في الأول لو أنا suspecting solid pancreatic mass I go for CT not for MRI. ال MRI لو ال CT كان non-conclusive I go for MRI to evaluate اللي أنا ال suspected clinical scenario إن أنا suspecting pancreatic lesion وما بانش حاجة في ال CT كان negative. أو إن أنا عندي pancreatic cyst I go directly for MRI not for CT. هم دول الانديكيشنز فور ام ار اي. طبعا بقى لو في كونترا انديكيشن اصلا للكونتراست انجكشن في السي تي فمش هيفيدني في حاجه ان انا اعمله نون كونتراست. ممكن اكتفي بالنون كونتراست ام ار اي هيديني بروبر ايفالويشن، خاصه ان انا عندي البانكرياتيك بارينكما ممكن ان انا اشوفها سيميليتنج الانهانسمنت في البري كونتراست تي 1، فهيديني داتا اكتر من اللي هيديها لي النون كونتراست سي تي. فدول الانديكيشنز. او ان انا بعمل بروبر بلاننج وانا خايف يكون في عندي ريسك اوف هيباتيك ميتاستاسيس. لو في suspicious لهيباتيك ميتاستاسيس I go for MRI for the hepatic not for the pancreatic lesion. يعني احنا الدايركشن سوليد، نروح على السي تي فيرست، لو السي تي جاب الكونكلوجن خلاص end of story، لو كان نون كونكلوسيف نروح للام ار اي. لو انا عندي cystic lesion I go directly for MRI واسكيب السي تي.
طب لو انا عندي حاله pancreatitis not responding to the treatment I'll go for MRI.
الام ار اي هيبقى احسن من السي تي فور ايفالويشن اوف الكونكرنت كيموراديوثيرابي، لان انا مش بعتمد بس على المورفولوجيكال ايفالويشن. احنا كان عندنا ستادي عملنا لها بابليكيشن بالايفالويشن للديفيوجن، ان احنا ازاي نجيب الريسبونس بالديفيوجن للكونكرنت كيموراديوثيرابي بعد ما العيان ان هو كان بوردر لاين ريسكتبل واتخذ الكونكرنت كيموراديوثيرابي وجو بعد كده فور السيرجري، وكانت الريزلتس ادكويت ان هم فعلا جابوا ريسبونس بيزد اون ذا ديفيوجن ان سبايت ان المورفولوجيكال داتا والسايز بتاعت التيومر كانت اولموست نوت تشينجد. يعني الديفيوجن هيبقى مور هيلبفul، خاصه ان البانكرياس بيبقى حواليه اكستنسيف فايبروسيس وادهيجنز جامد اصلا من البرايمري تيومر لان هو بيبقى فايبروتيك وبيزيد اكتر بعد التريتمنت. فهل ده فايبروسيس ولا ده ريزيدوال تيومر؟ ده اللي بنقدر نفرقه بالديفيوجن. فالديفيوجن هيبقى مور فاليبل في البوست تريتمنت ايفالويشن.
ثانك يو فيري ماتش. دكتور عاليه، سؤال برضو بالنسبه لل مالتي بارامتريك فيرسس باي بارامتريك. اوكي، احنا عارفين البريفرال زون المين بال سيكونس هو الديفيوجن ستادي وكان بي موديفايد باي الدايناميك كونتراست انهانسمنت. اوكي، طب في الباي بارامتريك انا ما بعملش دايناميك، فانا بعتمد على قد ما انا فهمت بعتمد على الديفيوجن فقط في البايريتس، صح؟
تمام.
اوكي. طيب يعني انت الريكومنديشن بتاعتك زي ما انا شفت كده في الاخر ان انا I go for بايبارامتريك و during الاكزام I can proceed او اغير لمالتي بارامتريك according للداتا اللي انا شايفها. يعني اي عيان جاي لنا بنبتدي بالبايبارامتريك if it's okay ماشي في الاول لغايه 3 احنا شغالين بالبايبارامتريك، اذا كان 4 او 5 هنخش على المالتي بارامتريك.
هو 3 هو اللي بيحتاج المالتي بارامتريك. 4 و5 خلاص مش محتاجين مالتي بارامتريك بالظبط، لان الديفيوجن لو حدد ان هو 4 الكونتراست مش هيعليه، و5 مش محتاج، بس هو بتبقى 3. هي الفكره ان الريكومنديشن لسه ما اتغيرتش من المالتي بارامتريك للباي بارامتريك بسبب الكواليتي بتاع الديفيوجن ويتد ايمجز. يعني هو لحد دلوقتي it is recommended to use المالتي بارامتريك كباك اب سيكونس علشان الديفيوجن ممكن across the different centers ممكن ما تبقاش homogeneous، يعني ما تبقاش في good quality diffusion weighted images. بس لو we reached good quality diffusion weighted images ساعتها recommendation may be changed إلى الباي بارامتريك، لكن هو ده لسه لحد دلوقتي ما حصلش، بس more research is needed. يعني حتى في بايرادز version 2.1 اتكلموا عن ان هو more research is needed عشان نقدر نحدد ال true value بتاع dynamic contrast weighted images. فهو up till now لسه recommendation ان هو multi parametric، لكن if you have good diffusion weighted images we can rely on diffusion في most of the cases.
طيب ده هيجرنا لسؤال تاني بقى، هو الرول بتاع ال 1.5 تسلا ماشينز على المالتي بارامتريك. هل انا في استطاعتي ان انا اعمل 1 ب 1.5 مش ما اعتمدش على 3 تسلا ماشين لو انا عندي هاي جريدينت سترينث وعندي فيزد اري كويلز؟
It is possible ان احنا to rely on 1.5 تسلا machines. احنا في الدمرداش يعني we rely on 3 تسلا لان هو it is the best recommendation. بس in case ان الماشين فيه يعني it's not working برضو we do not cancel. ممكن to rely on 1.5 تسلا لان actually احنا عملنا حالات في الاول بال 1.5 تسلا it is recommended ان الحالات تتعمل على 2 machines ونتاكد ان البروتوكول is optimized في 2 machines. وده كنا بنعمله في الاول. فحاليا you can do it on 1.5 تسلا بس in case ان ال 3 تسلا is not working. دايما الافضل ان احنا نستخدم 3 تسلا.
اوكي. في ال 1.5 بتستعملي 2 كويلز مع بعض، البودي كويل ومع السباين كويل.
ايوه بالظبط.
مش كده؟ حد تاني ليه اي اسئله يا جماعه؟ اوكي. اوكي يا جماعه، كده احنا وصلنا لنهايه السيشن. اشكركم على الحضور وشكرا للبرزنترز.